I was concerned about
That. Yeah, I've been to 3 sessions and that exact thing happened.
but maybe I think people were able to get the gist of what
Yeah.
I was trying to show.
But it was smart to skip the last one.
But in terms of like getting this.
Yeah, so yeah.
It's kind of glad we underplanned.
I, I was saying that I think this is might have been the first session ever where it did everything finished on.
Yes.
Okay, we had a funky video, but so.
Yeah.
Yeah.
The other thing that was cool was,
Country, like there was a woman here from Kenya.
You know, so.
yeah, actually, one of my colleagues was answering a lot of this last time.
Exactly.
Yeah, I know Christy was doing that, yeah. It's like,
Really appreciate
The answers, right, and not just those questions, so.
Yeah.
I hadn't really anticipated that.
Yeah.
We were just like.
Blending webinar was.
yeah.
But like when you have these multiple organizations and everyone has extra people in the room. It's
Yeah.
nice to.
Yeah.
There's lots of credible people to answer questions.
Yeah.
Remind me, okay, which room are you?
Red Bud, the one like very middle.
Redbird and
in the
Azalea.
front. And then Christina's Azalea.
Azalea and Red Bud.
Yes.
That's where I was keeping track.
I'm heading over to Red Bud too.
Yes.
Awesome. Okay, so yeah, so yeah.
And I was curious what overlap there will be, because this was all Washington schools. and
Yeah.
they're about to go.
Okay.
I don't know how schools work.
Yeah,
I know.
Yeah.
Yeah, I
will
take them.
Yeah.
Okay.
We don't think we have any in the office.
Yeah.
So I will take them.
And then like not too much sweet, yeah, because I think it's fine, I'm not cooking anything. These are awesome, but I also think they have the soft concentrations of them. I can share it with you. Yeah, whenever, I'll. Like when we're all back and settled, because I was looking to put on my slides, which is like, oh, it's over here. No. I also really liked working on the curriculum, but I don't know how, but it was like, no, but I don't feel like it was really nice hearing you talk about it, because I was like, I like, first of all, I really like the program, but I also really like the culture, like. And it's really nice, honestly, like you are the voice for like the good at you know what I mean? And like, I think that that's really good. Like, we're really so passionate about World Talk. And like, when I went to the postmortem in Kenya, the lead trainer for that project is like literally here.
Okay.
And I went to Kenya for the postmortem, and it's like teacher, like, I just feel like teachers, like, they have their training manual like totally marked up. And they have so many ideas and so many opinions, and it's like, I just feel like they are like, this is for us.
Yeah,
Which is great.
that's the thing, like I was so highlighting on this point because it's very nice to see, you know, an organization which is working on it and also involving so much. You Yeah, lower. Well, no, even in there, like, I'm very nice.
All the mayors and everything. And we were starting webinars this time, right? The yeah. Azalea's up and started. Are these like mobile presentations or here? Probably before they will come. Yeah, it was like they went back to the first slide, it was hard to tell. Yeah, I feel like I have the same. Case studies to stick for compliance. That doesn't really know.
That is mine.
Okay.
Taylor,
You
Taylor
are-
Simmons, I'm the first one.
Yes,
Yeah.
okay,
I'm sorry, I didn't, send you slides beforehand when I uploaded them.
you're totally fine.
Okay.
Where did you end up saving this? Did you just save it to the desktop?
Thursday verbals
Okay, cool.
and maybe to the desktop as well. If you want them. Okay.
Verbals.
I only noticed three, including mine.
Okay, I am seeing one in this folder.
Yeah.
Maybe they just got the other. Possibly, yeah. Cause I did notice another one, another two. One I didn't touch, the other one I accidentally closed out of, so,
Okay.
yeah.
We'll figure it out.
This time, let's try water presentations first. We can do, and I'll reset it and reset. Yeah. What? I just figured. I was like. Yeah, that should be recently happened. 305, 306.
Keep it yours, yeah.
Okay.
Yeah.
Listen to.
Yeah, we got one more.
Yeah, can I let it?
Yeah, absolutely.
Maybe that's the third. I think there's only three, right?
Yeah. Yeah.
Maybe you did one.
Everything's fine. We're all fine. Yeah, I'm supposed to try it the first time. And do you need any help loading up or are you good?
I think I already.
Sure.
You can sit.
just sit in the front, because I have my little 2 minutes. Minutes?
No, it's 3 minutes and 1 minute.
Absolutely.
There's a little time.
Oh, looks like we have.
That's just.
That's yours.
No, that's not mine.
Okay.
I mean,
Yeah, I'm not
if
seeing
that's
that.
all we have,
I'm not gonna have one. I think I'm gonna just sit tight because I feel like it probably, a lot of them have gone running around. Cool.
No problem.
huh?
Or, okay,
Oh, I don't hear.
try.
Oh, I'll ask him.
Are you gonna sit here? Well, let's meet here since this thing. But now, did well last one.
Thank you. Because everyone was very like good about trying. I just always feel bad because I wanna let everyone get it.
Oh, don't worry, I just want everybody.
Yeah. I have questions lined up.
Oh, no.
No, I actually don't have questions lined up.
How's it done?
So, okay, how you doing?
Pretty good.
Yeah.
You got all the labs, like how organized? No?
I am making progress, though.
Yeah.
Yeah. Yeah, so. Yeah. get over here.
I spent 12 minutes at the.
Yeah, so you'll get, at 12 minutes, you'll get a 3-minute warning, and 14 minutes, you'll get a 1 minute warning.
Oh, okay.
And then, we have,
Yesterday, I feel like they were giving like a 3-minute warning before, 12 minutes, like, I don't know. I
uh,
feel like mine's like 13 minutes.
yeah, I'm not sure. I think there has been some variability, but,
So that's it.
because all the presenters have at minimum 15 minutes. But since we have the whole thing for an hour and a half, or hour 15, and for 4 presenters, I like to like let an extra 1 or 2 questions come in at the end, so. Probably just 15, 17.
When somebody goes to my yesterday, they like saw the sign at 12 minutes, and like he freaked out and like skipped a couple slides, I'm like,
Yeah.
yeah.
I know, I feel like it's a mental thing, like, oh no. Yeah.
Really fast, stop at 10 minutes, I'm like, I have started my results. Like, I can see the clock and I was time. What do you got? Awesome.
Is all your stuff.
I just looked at it.
I just.
You wanna live that there?
I need to update.
Oh,
I haven't updated a copy.
all right, Kyle. You have time.
I was just too excited. I got it. Kyle, I'm presenting on the systematic review. I have a question for you.
Okay.
That you helped out with,
Yeah,
and I was wondering if it's okay, I think you're not with me, so okay to. Okay. Because I want to still give you credit too, since I know you helped out a lot,
Yeah.
so.
I did a lot of the like upfront work, but.
And then now you can see all the.
Yeah.
We've done so far, it's still ongoing, but it's taking a bit.
Yeah, I heard so. But like you have like results.
We do have some results. Enough to present, I guess.
Yes. Where should I put it? Do you have a flash drive with it? Yeah, I can. Good job. Oh, that's
Choir.
official.
Yeah. Oh, that's the worst midterm this morning.
Oh, no.
Oh, how'd you go?
What class?
Huh?
How did you go?
It's like the fundamentals of epidemiology.
Uh-huh.
It was not an easy exam.
That doesn't
at all.
sound easy.
No, it was in an hour, 15 minutes, it wasn't bad.
Uh-huh.
There's 22 questions and everything was like short answer
Mhm.
with some like 2 by 2 table calculation by hand.
Oh, wow.
And then, like, the professor was like, all right, everyone, like 5 minutes, everyone was still in the room, like furiously writing. And then he's like, okay, now everyone turn it in, and everyone was like still sitting.
Yeah.
So like, I don't think a lot of people. But it wasn't like, it's fine.
That's good. You have
So,
it's on.
yeah, I have yours. Just want to check.
Yeah, I just put it in.
I'm gonna have to.
Probably
Right here. So she'll give you a warning, 3-minute warning, 12. Then 4-minute warning, 14.
Yeah.
Okay, and then I like to, after 15 minutes, I'll probably skip like 1, 2.
I get it, well.
Yeah, cool. So sweet. Yeah.
I just pull it up.
So, you can open a copy of it. Okay. So you don't. You're still trying to get
Oh, like yesterday.
Yeah.
The buyer version, very interesting. I
Yeah.
don't know what that was.
We said that's my childhood.
Oh, really? I actually never really knew how something water filters work.
Yeah.
Like, I didn't know that you use sand and water shells to filter water. No, but I think it's very interesting. I'm not a lab person. Extremely something. Calculation.
I mean, I am, and I'm still.
Have you tested water from a high school science project?
I'm actually presenting it. Okay. I'll let introduce you to someone. Okay. What's that? Hello. I want to introduce. Wait, this is they I love it. Like that. We can write about that. We're gonna do a little work. Yeah, that's fine. No. I'm with this thing.
Oh. Working with it.
Oh, okay.
Not related to this, but the global health concentration is having one at some like country club. Often, okay. So I need to do that. I still have like 20 gallons or 20 miles left in my car, like gas wise, so I need to get gas
Yeah.
immediately
Go over there.
and then go there. Then I have a meeting at 7 p.m. And then I have to go home.
Are you not?
Hmm?
Are you already?
No, I'm a TA, yeah.
Oh, you're a TA.
Yeah, yeah. So I'm done here after this, but not done with
Yeah.
anything. Yeah.
Yeah, I just kind of like slow down.
Yeah. I do have to be back here at 7:30 tomorrow. And then I'm driving to DC right after this. No, I used to live there and my friend was like, was everybody from here.
Yeah. Really excited to be
All right, cool. Welcome everybody to the Windflower. Sorry, I keep getting the room names mixed up. Yeah, anyway, but congrats for making it to our last verbal session of the conference, right? Give yourself but yeah, today our topic is water quality. So please welcome Taylor Simmons from Water Quality Research Foundation and University of Arizona.
I have to share screen.
Sorry. Got it.
That's okay. Awesome. Thank you so much for the introduction and to you all for being here. My name is Taylor Simmons. I'm a graduate researcher at the University of Arizona. And today I'm going to be talking about a project conducted with the university and with the Water Quality Research Foundation. So to start, I'd like to mention that all public water systems in the United States are protected under the Safe Drinking Water Act and regulated by the EPA. So the EPA creates these Safe Drinking Water Act standards. I believe there are about 90 standards to date on common contaminants like uranium, arsenic, and hopefully PFAS by the end of the year. And so from there, state primacy agencies are elected to enforce these standards at public water systems within their state. And in general, the Safe Drinking Water Act strives to provide safe, clean drinking water to those served by public water systems, but we know this isn't always the case. For instance, last year, of the 54,000 assessed public water systems, over a quarter of them were non-compliant for one or more contaminant. And here's an EPA tool to show you non-compliant public water systems within your area. So here are the Safe Drinking Water Acts, or the water treatment steps
in general. So first, water is pulled from a source and it's sifted through treatment plants. And then sometimes it's stored and delivered to the community. The community could be apartments, homes, schools, hospitals. And ideally that water would be safe and clean to drink, but we know sometimes there are treatment failures, stagnation of water post distribution, intrusion of microbes, and even aging infrastructure that could impair your water quality. And the reality is the inability of treatment plants to remove all contaminants all the time requires the use of a point of use or point of entry treatment device to reduce exposure risks at the tap. And this is really effective. So for those who don't know what point of use and point of entry is treatment for all the water sources in your home. So that's treatment for your kitchen, your bathroom, and even your washing machine. And it typically requires a large storage container, whereas point of use is just treatment at the tap. Now, it's important to mention that if these devices are ANSI or NSF certified, they are designed for a specific contaminant. So if you have an arsenic issue, pop in one of these devices that are certified for arsenic, and it will be guaranteed to remove some of that exposure. Hopefully below the Safe Drinking Water Act standard if used appropriately. In 2006, Congress authorized public water systems to use point of use and point of entry, but they left it up to the state primacy agencies to decide the rules governing procurement, buy-in requirements, implementation, maintenance and monitoring, you name it. And similar to the underground injection control regulations on the right, state regulations and policies vary for these systems as well. The EPA attempted to summarize these state policies a couple of years ago, but major gaps still remain within the data. To start, in their report, they assessed 24 of the 50 states, and of the 19 questions asked, about a quarter of them went unanswered. And so, this study seeks to fill in those gaps and better understand the successes and challenges of implementing these systems on the state and ground level to promote informed decision-making of public water system managers, policymakers, and homeowners interested in determining solutions for water quality impairments. So here's kind of a Safe Drinking Water Act pyramid, if you will. So the EPA creates these standards, state primacy agencies ensure that public water systems within their state are up to date on those standards. I believe the state primacy agency for North Carolina is Department of Environmental Quality. And we separated the study into two phases. First, we wanted to know if the state primacy agencies even allow these systems. And if they allow them, are they implementing them? What are the policies, costs, successes, and challenges of these systems? And then we wanted to get a better understanding of public water system manager experiences on the ground if the states allow them to implement these systems. So for phase one, we separated them into three groups. We wanted to know if they were allowing and implementing these systems. We started off with 316 contacts, attempted to reach 50 states, and only got 38 responses, which is still pretty good. Oh, and I forgot to mention too, the study took place from 2022 to June of this year. And so from there, if those states allowed and implemented, we prompted the respondents to share public water system contacts that are actively implementing these systems. So we got 32, and of these 32 responses, 11 replied back that represented 4 states. So just because of my time constraints, I'm just going to talk about groups 1 and 2 for phase 1 and delve deeper into Oregon for phase 2. So here's a map of our results. In blue are the states that allow and implement these programs. 18 states allow both. 3 states highlighted or outlined in yellow only allow point of use, and 2 only allow point of entry. In yellow are the states that are allowing but not currently implementing these systems, and in red are the states that do not allow these systems. So for those that do allow and implement, they shared that most of these systems came from public water system budgets. When prompted to share their infrastructure grade, they rated their infrastructure at a C and D, so not the best. Some successes of these systems was that the device met their objective. It did its job in removing whatever contaminant they had issues with. It was cost effective too, more cost effective than upgrading and repairing the treatment plant. And these were stakeholder driven results. A lot of these states require 100% buy-in for implementation. They also shared barriers like finding funding, EPA guidance documents, achieving that 100% buy-in requirement. And it's important to note that 3 states reported no barriers, that implementation was smooth. So for the states that don't allow, 10 of the 38 responses They rated their water infrastructure grade at a C and B, so a little bit better than the previous group, but these are large expenditures. Alabama shared that $5 billion, in Connecticut, over 60% of their public water system expenditures are dedicated to Safe Drinking Water Act compliance and infrastructure. Some barriers that they shared were, again, compliance. They weren't sure if these systems worked, costs and operations and maintenance of these systems. As for overcoming their barriers, they shared that they, again, were unsure, clear EPA guidance, and additional personnel training and funding. So delving deeper into Oregon, from phase 1, we learned that Oregon allows and implements these systems. There are currently 11 through 20 in the state that require 100% buy-in for implementation. Also, training is required for operations and maintenance of these systems, but there is no system size or type criteria for implementation. So from phase 2, when we asked public water system managers on the ground, we got 3 responses from Oregon. We learned that point of use and point of entry was cheaper than upgrading or repairing the treatment plant to maintain long-term Safe Drinking Water Act compliance. The successes are the contaminant specificity. Again, it did its job, and cost effectiveness. However, one of our respondents shared that Oregon is phasing out a point of use, which is currently driving up the costs and making availability of filters harder to deal with. For phase 2, we also prompted our public water system managers to share recommendations for those interested in implementing some of these systems. So they recommended in-house sampling, so don't hire out, do the sampling yourself, and tailoring unit size based on water usage. You don't want to filter water you're not going to use and spend that energy and money. We also got their community buy-in methods for achieving that 100% buy-in, as well as demographics of the 3 sites and timelines for planning, piloting, and implementing, which could be useful if someone's interested in implementing one of these systems. Say that's for site 2, fully a Caucasian community, and then tailoring your outreach methods. In addition, when considering these timelines and how urgent your need is for compliance, taking that into account. So how do we use this information? I know I just threw a lot at you. The big picture application. There are about 2,600 public water systems in Oregon, and only 11 through 20 of these programs in the state. Last year, of the 650 assessed public water systems, about a quarter of them were determined to be out of compliance for one or more contaminants. This is an issue that could potentially be solved with the implementation of more point of use or point of entry treatment devices. So, our study sought to better understand the successes and challenges of point of use and point of entry implementation at the state and ground level. We figured out the state policies, costs, successes, and barriers of these systems. And for those that did implement them, we wanted to understand the public water system manager experience on the ground, and we did so. So water is a shared, limited resource. Over 350,000 chemicals have been made in the last 70 years, and most go unregulated. In addition, climate change is straining our water resources, especially out west where I live. And we're noticing that the more groundwater we pump out, the lesser quality it is. It's important to mention too that private wells are not protected by the Safe Drinking Water Act in the states. So if you're a private well owner interested in implementing point of use or point of entry programs for your water quality solutions, look for those ANSI or NSO certified devices that are tailored to the contaminant. Also look for the report to be published soon. We're still in the final stages of revision. Awesome. Thank you all for being here, and for the public water system managers and state primacy agency employees who shared their comments and remarks with us. That's it. Any questions? Sure.
Or this one.
Okay. Just a question about like when somebody has a point of use or point of specifically a point of entry to use, I guess, either one at their house, does that raise alarms for the actual household? When they are maybe asked to put that in by a community because they don't want to invest in treatment? And do they fear that, you know, there's something wrong with their water because they're actually putting these things in?
Sure. I think for our phase 2, when we asked public water system managers about this experience, we asked them what the community felt, or if they did any community surveys before implementation. And a lot of them were scared. They're like, what do you mean my water is contaminated? But it was cool after outreach and education, sharing how effective these devices were. They got over that. And then they noticed how good the water tasted. And they're like, all right, I can get down with this. Meeting and scheduling meetings every month or however often they come in and do maintenance. So, yeah, we got a question in the back and in front.
A couple of quick questions. One, maybe I missed it, but did you talk about what is the average size of the systems? And did you look at that? And then what was there, did you look at which contaminants they were addressing? Was there like where they wasn't, was it lead concerns? Was there kind of a consistency in what they were trying to address as the kind of all the like particular contaminants?
Yeah, let me address your second question, sorry. We did ask them if it was inorganic or organic contaminants, and so it's kind of a binary response, and they were offered the choice to expand a little bit, because we got a lot of uranium and arsenic, especially in the Northwest. That's just all I can remember off the top of my head, but yeah, the specific contaminants, and I missed your first question.
Sure, typical size.
Oh, typical sites, yeah. So a lot of these point of use and point of entry programs were for smaller systems, small public water systems are very small. I think it's categorized by the EPA because they're doing so much maintenance and have to go in and, repair them as necessary for them to work effectively. So, yeah. You have a question up front, Kid?
I just wanted to ask about volatile contaminants. I know, MCLs are sometimes calculated based on not just drinking, but showering and cooking.
Mhm.
So I'm just wondering if people with higher levels of volatile contaminants would advise to go for a point of entry versus a point of use, or who made that decision? Thanks.
That's a great question. I'm not sure if I'm equipped to answer that. But if it was a volatile contaminant, I prefer point of entry. It's a personal preference.
Yes.
Yeah. So, yeah. But I think that point of use in general, from the results that we're seeing, was cheaper than point of entry. You're filtering less. And so, yeah, it just depends on what you're concerned about.
Do one more question.
I got one. Yeah. So did the communities have concerns about their water quality before you came in? Sorry, I missed the very beginning of the presentation. So were any people already trying to take action on their water quality, or expressing, oh good, we needed this, thank you for providing it, because I'm unhappy with this aspect of what I wanted?
Sure. We didn't gather that information, whether or not it was community driven or not, but that's really interesting. From the few public water system manager surveys we did, we invited some to expand on their experiences over Zoom, and they had shared that it was internal, that it was the public water system thing. We need to protect our community. We live here. We know them. We need to do something different. So that's a good question. Okay. So thank you so much.
All right, please welcome Dorian Tosi Robinson from Eawag.
Good afternoon, everyone. Can you hear me well at the back? Yes, good. I'm going today to present the assessment that we have done on this local low-cost passive inline chlorinator in rural Guatemala. The study setting took place in the department of Solola in Guatemala, where 46% of the rural population do have access to safely managed drinking water, but all the rest doesn't. So there is still a lot of work to do for this. The NGO Habitat, which is our partner on the ground, was implementing and is still implementing the Rukusa program, which is a program that aims to improve wash services throughout all the departments. And we worked within this program, and what they do is they improve governance. They mostly build capacity at with different stakeholders, and especially with the local communities that are also in charge of their water systems. And within this program, they also installed the chlorination device, which is called the AHIN chlorinator, which we did the assessment for. One important point of the concept is that chlorine acceptance is quite low. people, or that's what we thought at the beginning, but stakeholders report that people won't accept chlorination because of taste and odor, and also because of some belief that people have that chlorine might be not good for your health. So false beliefs around chlorination. The Ahin chlorinator is a chlorinator made of PVC pipe parts built locally. You can find all the parts already available on the market there. It's installed at the reservoir tank of a gravity-fed water distribution system. We worked in small water distribution systems for 50 to 600 households. Water comes from a spring source, and it goes to the reservoir tank where the water is chlorinated with this device, and then it's distributed to the taps. Households had private taps at each household. A special point is that it works with water that is not pressurized, because all the systems there don't have good pressure in the systems, and it works with calcium hypochlorite tablets. Acutabs are available on the market, more or less, in Guatemala. And it costs $70 to produce. What we wanted to do in this study is to evaluate the technical performance of the device, on how well it can dose chlorine into the systems, and if it can reduce bacterial contamination at the household tap. But also, we looked at the drinking water. So we asked the people, what is water that you actually drink, which might be tap water, bottled water, filter water, boiled water, any water that they drink. We wanted to analyze the main challenges for passive chlorination in such setting, and we also had a look at user perception and behavior change due to the chlorination. To do that, we went through a lot of interviews at the household level, and also with the water system operators to have information about the water supply experiences, the perception, the chlorine acceptance, how the system is actually managed, breakdowns, and how did it go using the Ahin device for the operators. Water samples at reservoir tanks, taps, and drinking water, testing E. coli, coliforms, free residual chlorine, pH, temperature, and turbidity. This was a non-randomized control trial with pre-post intervention assessment, some control systems, some treatment systems. Treatment systems receive the intervention, and then we test before and after this intervention. We had a lot of trouble of finding systems that actually wanted to have the water chlorinated. So we have much less samples or a number of systems that worked with us in the end. We have 4 systems that actually installed the Ahin chlorinator, and at N-line only 3 were actively using it. And you will see this distinction in the results. This is why I mentioned it. And we also did some regular monitoring, but today I'm not showing you any results on that part, just the before-after comparison between baseline and N-line. So what happened for the tap water quality? Here it's shown with the risk-based values, but at control and at the actively chlorinated systems, for both, we had significant reduction in mean log 10 E. coli concentrations. So for both control and actively chlorinated. For the systems that are chlorinated, we also didn't get rid of all the E. coli. There is still, it's only 1%, but there is still E. coli present in this case. For the drinking water quality, we have a little bit a different situation because there is no significant difference for the control systems, but we saw a significant difference, a reduction in the contamination for the actively chlorinated systems, which is great. But now, just before I said for the tap water, we saw a difference, a decrease for control and for treatment. So we don't know if it's due to the chlorination or not. So what we did to assess whether it's because of the chlorination or other external factors that might be seasonality, rainy season, not rainy season, and other factors that might be the intervention from the NGOs in the communities, hygiene promotion, and any other thing that can influence water quality. We ran a difference in difference analysis, which allows us to isolate the effect of the chlorination. And what we find is that for taps, the chlorination is actually responsible for most of the total reduction, 90%, both for E. coli and total coliforms. And for drinking water, 80% of the total reduction for E. coli contamination is due to the chlorination, but for total coliforms, we didn't see a significant change in the values. These are the results for water quality. Now, we also wanted to have an idea of how well the chlorine was distributed throughout the system, because it's what we want, that chlorine is everywhere. And we saw that only most of the sample actually didn't show chlorine presence in white you see here. So at tap, 42% didn't have any chlorine, and at the drinking water, 59%. And in range of what we want at the tap, we have only 24% of the samples that were between 0.2 and 0.5, which is what the Ministry of Health was aiming for, which might be a bit too low, and probably is too low, showing looking at these results. And note as well that we did the end line in a phase where the systems were still working on finding the right dose for their system. So there is a little bit of bias here. And what's good is that we don't have overdosing of the systems. So this is important for the perception results afterwards. And between tap and drinking water, the free residual chlorine concentration mostly halved. What we saw for the system operations is two main technical issues. One is that the dosing with the device was a bit tricky. It had low precision with the valves that are used in the device, and some difficulties then to adjust the dose to exactly what the operators wanted. So they had to a little bit play around and find a way to make it work as wanted. And we also saw clogging of the device that required quite often cleaning of the system. And this links to the management challenges, because the operators that work on this chlorination device, they are not paid. They do this on their time instead of working a paid job. And it's a time-consuming task, both for changing chlorine tablets and for declogging, cleaning the device if it gets clogged, and especially because the water reservoirs, they might be quite far away from the communities, and to go there, you walk most of the time. And lastly, one of the challenges was also access to the chlorine tablets, because you cannot go to a shop and buy them. They are dependent on other stakeholders to provide them the tablets for now. The proper tablets, because you can find other tablets on the market which are not the ones that we wish to use. These are the challenges. For the user perception, this one is also interesting, because most of the users are very satisfied with their water distribution system. We saw an increase of satisfaction for the treatments that received chlorination, slight increase. And for taste and odor, people are satisfied, and we didn't see a significant change at endline after the installation of the chlorination, and very few people actually detected presence of chlorine, both for odor and taste perception, which we were a bit surprised. I mean, the dose of the chlorine was low, so somehow it makes sense, but we were surprised because all the time we could hear that people would not want chlorine because of taste and odor, and the results that we found is that at least at these concentrations, that's not the case. Some of the limitations of the study, in the end, we have a smaller sample size than the one we wanted. We still are able to do some conclusions, but they are more limited to internal conclusions, and we cannot extrapolate externally so much. We had a very short follow-up period for the installation of this is because of COVID and many other things of project implementation, but installation of chlorinators happened, and only 1 to 2 months after that, we managed to do the end line. So very short after the installation. So we don't have information about long-term sustainability of the chlorine device, nor how well the operators will get trained and able to use it probably better, hopefully, in a longer term, at least to get the dose right. And we didn't measure any health outcomes. We measured E. coli as a proxy for water quality, but we don't have any information on did the health of the people actually change because of the installation of the device. So our preliminary conclusions, we had significant reduction of E. coli contamination at point of collection and at point of consumption due to the chlorination. The device is low cost, accessible, repairable, and adaptable to the different systems that are there in rural Guatemala. But we saw frequent needs for maintenance and some operational challenges. The user satisfaction was high and perception of chlorine and taste and odor was low. And one important thing from this study is, to my knowledge, there is no other study on locally built chlorinators such as this one. So it's somehow the first results that we see on technologies that can be built from the ground, adapted to a context. But one thing is that it must be worked on to ease the operation and maintenance of such technologies because of all the other constraints that are around. So if they are not working perfectly as we want, it might be causing some failures. So it's a key to success to work on operation and maintenance and make it work properly. We would like to thank ETH4D for funding our research and our partners on the ground, Helveta mostly that worked hard to gather all this data, and thank you for your attention. Questions?
Hi, Dorian. Awesome presentation. Thank you so much for sharing this information. My question is, and maybe I just missed this, but if it was a locally built inline chlorinator, why was it difficult to locally source the actual chlorine tab?
So the system, the chlorinator itself, you can build it with the PVC pipes that are available locally. But for the chlorine, we rely on existing markets that are in Guatemala. And actually, there is a big problem in Guatemala with the use of tablets that are not for drinking water purposes. And there are very few providers that manage to give you hypochlorite tablets that are for human consumption. And so, yeah, it's tricky. I mean, what the project wanted is that we don't bring the chlorine there, but we use existing markets to make it work from the ground up, and also for the health ministry to take this on afterwards.
Hi, again, just reiterating that really interesting presentation. Just a quick question about, now that you've got these findings, and you said that the system, they're still kind of maturing the operations, figuring out how to work with the system. So what's next in terms of this research and in terms of working with these systems?
So on our side, as a research institute, we are now a bit hands-off of what's happening. Helvetas on the ground is working to improve the device slightly, and it's continuing. They are continuing to install them. Actually, not even Helvetas, but the health ministry in Guatemala. They already installed, I think, 50 now of these devices. So next step, I think it would be nice to go there again at some point and have a look at how well it's performing in the systems. But we have, at least from the Eawag side, no plan for that right now. Hopefully we can count on Helvetas on doing some assessment or getting some data from the health ministry as well, because they were also trained to gather both water quality data and free residual chlorine that we might need. But they don't do as much sample as we did here. Yeah.
Thank you.
Do maybe like one.
Yeah, great work. I was curious if you looked at all the effect of turbidity or pH on your bacterial removal.
Not yet.
Okay.
We might do it because we have the data, but we have not looked at that yet.
Wait, can I have one follow-up question? This is kind of unrelated, but I was also curious just your opinion on the pros and cons of having a system where it can be locally made, but it might require more maintenance and operation versus something that you could get from a manufacturer that's like been highly tested and all of that stuff? What your opinion is?
Okay. I mean, some technologies are not adaptable to the context of Guatemala, even if they are manufacturers and everything. And if you do that, you also rely on a supply chain from outside. And we had a lot of talks about colonialism before, and I still see that as colonialism happening somehow. So building it there and having it grow up from scratch and from the country's needs, I think it's great. But it has pros and cons. It's not working perfect, it's working.
You can do it right here.
All right, next up, please welcome Kyle Rezek from University of North Carolina.
Okay. Hello, everyone. My name is Kyle Rezek, and I am a student at the Aquaya Institute here at the University of North Carolina, Chapel Hill. And I will be talking about toxic metals in drinking water in low and middle income countries, which was a systematic review we are currently working on. And I am proud to share our preliminary results so far. And this work could not have been made possible without a variety of contributors helping out. And some of these people are listed here, and then at the end as well, acknowledgements. So a little outline before I begin is today I'll be going over why are we looking at toxic metals in the drinking water? Why was a systematic review chosen for looking at low and middle income countries? The methods, both the bibliometric evidence gaps and toxic metal occurrence by region, some resulting student projects, and then the discussion and next steps. Some background is that toxic metals and metalloids, or further known as TMs, can occur in drinking water from a variety of sources, whether it's geogenic or anthropogenic sources. Exposure to these can cause numerous health effects, making the removal of them from the drinking water of high concern. Some of these toxic metals are more prominent, such as arsenic, lead, and manganese, while others are more indicators for finding those more toxic metals in the water or in different areas, such as copper, iron, tin, and zinc. Why was a systematic review chosen for this topic? Currently, there is limited evidence available on this topic, and the evidence that is available often is highly localized or linked to contamination or linked to localized sources of contamination. It can also be obtained using unsuitable or insufficiently sensitive methods, and previous studies also report using summary statistics, which can obscure important patterns in the data, such as reporting only mean values for log normal data. These limitations can impact the internal and external validity of many of these studies while making evidence synthesis and meta-analysis challenging. This has been part of an ongoing effort to synthesize and disseminate evidence on toxic metals in drinking water in LMICs. While this is the first study to synthesize evidence using a systematic review and meta-analysis of peer-reviewed studies in accordance with the PRISMA statement items, though this study may not have been feasible before due to the tremendous amount of data and different studies out there, the use of machine learning, AI, and simplifying assumptions has currently made it possible. The methods undergone were searching several databases, as mentioned there, such as PubMed, EBSCO Global Health, and Web of Science, and our criteria to include the studies included, they must be published in English, it must be a peer-reviewed study from 1980 to the present, it must report on quantitative primary data of the toxic metals that previously mentioned in the earlier slide, and it must be used in drinking water in an LMIC country. Over 30,000 results were returned, and a machine learning algorithm screening a subset of 500 results, and then an algorithm screened the remaining results using supervised clustering. And this work was done, the machine learning algorithm work, was done by Michelle Colley at the UNC Health Science Library, at the Health Science Library. After that step, the screenings and title abstract were manually screened of around 7,300. And then further on to the full text studies of 3,500 studies. After those were then analyzed and either included or excluded, the included studies, which is currently around 2,000, are currently being extracted for the data. The extracted data was scored on a risk of bias depending on threats to internal and external validity, and the data was formatted to be comparable to the others, to a baseline study. A merged database was created, and the results were calculated using meta regression functions and stata for both the entire data set and high quality studies only. So these were the preliminary results that we have. Since the systematic review is still ongoing, these could then be updated as we get closer to finishing, but you see a large prominence of studies in Central and Southern Asia, as well as Eastern and Southeast Asia. And you can tell from the density map on the top right that India and Bangladesh had the most studies, with India having around 880 and Bangladesh having almost 600 studies reporting on toxic metals in those countries. No studies were found for some countries in sub-Saharan Africa, Latin America, and the Caribbean region. And as you can see on the bar graph on the bottom right, the top 10 countries by studies done and conducted were a mix between different countries from the different regions. So expanding on that, as you can see, most studies were majority were from Central and Southern Asia, and then Eastern and Southeast Asia and Sub-Saharan Africa were also large percentages, while only several percent were from Latin America and the Caribbean, and then only a few percent were from Europe and Northern America. For the toxic metal occurrence, around a third of the studies included arsenic and iron at 38 and 36% respectively, while some of the other metals, which aren't as commonly found, have not been reported on as commonly, such as uranium, mercury, selenium, antimony, and tin, and these were reported in fewer than 500 studies. So you can see there's more skew to the left with the higher amount of studies, and then the bottom 5 studies are much more drastically not covered. So some bibliometric evidence gaps that have been discovered is that there was a total of 85 LMICs out of 137 total. So this is around 60%. So there's a 40% of countries that are categorized as LMIC that did not fit our inclusion criteria, though there may be studies done in other languages or in other settings that did not meet our criteria that we could be missing out on. 44% of the studies from Central and South Asia, and then nearly 45% of studies from India, Bangladesh, or China, compared to the Latin America and Caribbean region, where only 9% of studies were covered. Arsenic was reported most frequently, while some other metals such as uranium, mercury, selenium, and antimony were all less than 10%, while fewer than 35 studies reported on uranium or antimony in the Latin America and Caribbean region. For the water source type, and was more than 50% of studies reported on water from wells and boreholes, and fewer than 10% reported on piped sources. The preliminary results from around the data extracted of around little less than 800 studies showed that there is a substantial occurrence of lead, arsenic, and manganese at levels of concern. And using the WHO guideline value for lead of 10 parts per billion, which is that black line in the middle of the box there, this is for arsenic, is around 10 parts per billion. For manganese, it is around 80 parts per billion, which you can see still the majority is above the WHO guideline value. And then for lead is the 10 parts per billion. And luckily the majority is below that level for WHO guideline, but there is still a substantial amount above that guideline as well. So many students have helped contribute to this work, and they have been able to create spin-off projects using the data and information that they have been working on. So one student, Joyce Liu, worked on the occurrence and distribution of manganese in drinking water in India and the implications for the population health. And she was looking at manganese contamination in India's drinking water using a variety of different factors, such as the geographic location, the water system type, and the season, whether it was monsoon, summer, or winter. And she was looking at determining overall effect on the population and whether there's a lot of people living around an area with a contaminated water source. Another student, Michael Tran, looked at the analysis of India's arsenic concentration in drinking water, geographically based, showing how arsenic concentrations in the drinking water could vary based on space, time, the system type in India. So this evidence can be useful for evaluating changes in arsenic occurrence and potential exposure over time, and then increased piped water access, demographic shifts, and so on. For some discussion and next steps, data extraction is still currently ongoing, so the analysis will then quantify the occurrence of toxic metals and LMICs exceeding the WHO guideline values. And this will be done overall, as well as disaggregated by the water source type, the SDG region, rural and urban classification, and the country income level. The preliminary results do show a substantive amount of lead, arsenic, and manganese at levels of health concern across multiple settings and countries, though there are a lack and dearth of studies reporting occurrence of TMs in Latin America and the Caribbean region, Sub-Saharan Africa, North Africa, and West Asia, as well as a lack of studies looking at several elements such as uranium, mercury, selenium, antimony, and tin. There's also a need for ongoing work to continuously update the study as more peer-reviewed studies get published, as well as to integrate gray literature, which may not meet the current criteria, as well as non-English literature, which may be missing some studies done in other countries or regions. I would like to acknowledge everyone at the Water Institute and the UNC faculty and staff that helped contribute to this, those at the UNC Health Science Library, those at the University of Ghana, Legon, Dr. Aaron Salzberg, Ms. Kata Lang, as well as the very numerous amount of undergraduate and graduate students who have helped contribute to this project. And without all their hard work and effort, it would not be possible. Does anyone have any questions?
First of all, how did you recruit and finish so many undergrads? And also, can you, moreover, can you tell us more about the algorithm you used to get from 30,000 to 800?
Sure. So for the student management is definitely it's tough, but it definitely kind of ebbs and flows throughout the semesters. And we usually just recruit students and then they work as they help us out with research assistant, and they're able to also develop side projects if they would like, such as the 2 projects shown. For the algorithm, I am, to be honest, not completely sure, but I can put you in contact with Michelle Colley from the Health Science Library, who may be more knowledgeable. But from my understanding was that there was 500 studies that we manually screened, and then we taught the machine learning algorithm to then go forward with the rest of the studies as well.
Yeah, I mean, it'd be great if that was so much unremarkable.
Thanks for the presentation. I was wondering if in some of your side studies, if you're trying to identify sources for some of these toxic metals in drinking water. I'm working on a chemical health risk tool for drinking water, linking sources to occurrence in order to predict some of these contaminants. So just wondering if that's something you're looking into with this rich database. Thanks.
Thank you. As of I know, not currently right now, but I think that definitely could be a possible topic we could look into in the future with all of our data once it's analyzed.
Hey, Carl, thanks for the presentation. I just wanted to know if you consider including like national data sets, especially in the regions that you couldn't find much evidence for, because I feel like that even if it's at an aggregate level, it's comparable one there, just the map would be interesting.
Thank you, Jose. That is definitely a good consideration, since there were some areas where the data was lacking and we didn't find it. Currently, we were just looking at peer-reviewed studies as well as primary data. But in the future, if we are noticing lack of data in other areas, we could definitely find alternative methods to including those countries in the data that they may have been.
Did like one or two more questions?
Is there a reason why you excluded high income countries?
We were mainly looking at the low income countries mainly because there was a lack of information like kind of accumulated with them, since it was the current information out there is very disaggregated. So we wanted to find an overall occurrence of where the metals could be in what regions.
Sure, okay.
Thank you for the presentation. My name is Robin. I am from World Vision, Ghana. Just wanted to find out what remedial actions are proposed. I looked at 38% trace metal, particularly arsenic. I think it's an alarming number in terms of percentage. So what is the proposed remedial action? And I mean, what is recommended to address the issue?
No, that's a great question. Thank you. I think, of course, our main motivation for this study is to determine the extent of what toxic metals are in low to middle income countries. To then the next step would be, how do we remediate? How do we remove? How do we protect the public health of those people in the countries? That is a further step than I am aware of, but I would definitely say a possible remediation effort would be like a filter you could use, or either granular activated carbon, which could be widely available, used to remove arsenic, or as well as other removal or filtration that you could use for the water sources.
Beyond the scope of your study,
Yeah, that's very beyond.
quite important.
Mhm.
Thank you, Kyle.
Thank you.
All right, please welcome Valerie Bauza from the Aquaya Institute.
Okay, thank you. Like you said, I'm Valerie Bauza with Aquaya, and I'll be presenting some characteristics of piped water systems in rural Ghana that we investigated as part of the Real Water Project. And like, many others have said, this is an effort of many other individuals, instead, not just Aquaya, not just me, but several folks, some who are listed here and some who are not, but I want to especially give thanks to our collaborators and colleagues at KNUST in Ghana. So as some brief background before we get into the specific study, for this study, we focused on piped water, primarily because, treated piped water is often considered one of the highest levels of service provision. And if you saw some of the other work that was presented by Real Water earlier in the week, that was comparing sort of different management schemes for piped water systems within Ghana, that work showed that there was better performance in terms of things such as functionality, reliability, and water quality for systems that were managed by donor-supported safe water enterprises compared to public provisions such as the public utility or community-based management arrangements within Ghana. And so for this specific study, we aim to characterize the operation of these piped water systems by a donor-supported enterprise within Ghana that we thought might have that sort of highest level of service within the different management arrangements. And then we also looked at some of the water-related practices and perceptions of households with access to this treated piped water in Ghana. And so this data was collected as part of a baseline assessment for a larger evaluation that I'll provide some details on at the end of the presentation. But we collected information from 92 water systems throughout Ghana by interviewing the operators and managers of the system, as well as conducting sanitary inspection of all of the infrastructure for the system, starting at the water source, but also considering the distribution system, the storage tanks, and the standpipes and private taps that distribute the water. And we also did water quality testing at those public standpipes as well as private taps, primarily focused on parameters such as chlorine residual, microbial contamination measured by E. coli, and some other parameters like turbidity and pH. We also, in a subset of households, looked at the water quality of chlorine and E. coli in the stored household water. To get more information on community perceptions and household perceptions, we did surveys with 20 households for each of the water systems and also held focus group discussions in a subset of communities. These systems were located in small towns and rural areas within southern Ghana, primarily like in the regions that are shown in blue on the map. And most of these piped water systems use groundwater that was chlorinated before distribution, and a few of them use surface water that underwent extra levels of treatment with filtration before chlorination. And then based on water characteristics, the water supplier had additional treatment steps for some of the systems, such as removing iron or hardness or additional disinfection. And like I said earlier, these are all water systems that were operated by a nonprofit enterprise that receives external donor support to supplement revenue from consumer tariffs. But they do charge a fee for collecting water, both at the standpipes or at the private taps for households. So I'm going to dive right into some of the key findings. And so we collected a lot of data about these systems, and I don't have time to go into all of it, but I've tried to distill it into, I think, 4 key findings along different domains of the water system. And so the first finding looking at these water systems was that consumers felt that the functionality was generally sufficient to meet their needs, but based on other metrics, the reliability could be improved. So for example, when we asked households directly if the frequency of the water supply was sufficient to meet their needs, 73% said that it was, but only half of households reported water was actually available from the pipe system every day. And almost 2/3 said that the water supply had been interrupted within the past month. And households reported this was often due to either a technical problem or a power failure. And these are household reported kind of measures of functionality and reliability. But we also asked the water operators similar questions about interruptions in the pipe service. And I didn't put all the details about that, but in general, the water operators reported lower levels of interruption than the households reported. And this can be due to, a number of different reasons, but some of it could also be how each one experiences the water system. So for example, if households are getting water from a standpipe, there's a standpipe vendor that has to open the system, collect their payments, and they have to be there in order for the households to be able to access water from that point. But the operator doesn't consider that. So if the household goes there and the operator is not there at a time, say the household expects them to be there, from the water operator standpoint, that's not an interruption in service because there's water in the tank, there's water that could be delivered to the standpipe, but the household might view that as an interruption in service. And so it's important to kind of think about where we're collecting the data, how different people and different users and stakeholders within the system might experience this and what that means when we think about these functionality and reliability outcomes. Next, we looked at the microbial water quality. And as is, typical, I think, in a lot of systems like this, we found that it was typically good at the point of collection, but it deteriorated before use. And so this graph shows the free chlorine residual in the standpipe and private tap water, which is combined in the dark blue bars, and then in stored household water, which is the light blue bars. And so the target recommended level is 0.2 milligrams per liter at the point of collection, in either at that standpipe or that private tap. And only 34% of systems had levels to meet that recommended guideline. And so, overall, even though there's a lot of treatment in these systems, often it wasn't getting to the level of chlorine residual that we felt would probably be necessary to be able to prevent microbial contamination in the stored water. And that is what we saw in general. So this is a graph showing the E. coli levels, again, in the standpipe and private taps, as well as the household stored water. And the green bars show, no levels of E. coli contamination detected in the water sample, all the way to the highest level of contamination shown in red, which is, very high levels of contamination. And so when we look at the standpipes and private tap water samples, we see 84% of those had no level of contamination. But when you get to the actual household stored level, that's reduced by more than half to only 41%. That is still, safe to drink, I guess, at the household level without any risk of exposure to E. coli or other potential pathogens that this is an indicator of. And this is important, even though this is a piped water system. And, this was a mix of households that use both the public tap and have these private taps, because even when the households had an on-premise connection, they were reporting that they still store their drinking water. And so, making sure there's that adequate chlorine residual to remove this contamination is important, even though it's a pipe system. Okay, now I'm going to shift to the consumer perceptions. And so many respondents actually complained about the water quality in some way and did not always use the piped water source for drinking. So even though this was, treated water, the treatment wasn't perfect. Among customers of the system, only 61% of those customers reported they use this as their main source of drinking water. And 27% of those customers said that instead they were drinking sachet water. And then there's a few, households that were using other sources within the community. But this, what I think is important about this is like when we look at that percentage using sachet water and other sources, this included those using standpipes, but also those that have these on-premises connections. So, in our focus group discussions and our surveys, we asked these households and these respondents why they didn't want to use the piped drinking water. And the two most common reasons were either they didn't like the smell or taste of the piped water, or that they believed the piped water supply was not safe, or that the sachet water was safer. There's a lot of promotion of sachet water in Ghana, so I think that is kind of a public perception, and the results are a bit mixed about whether it's safe or not. It can be pretty brand dependent. But what we find is there's complaints about the chlorine taste and odor, even though in a lot of these systems, we're seeing they're not even at the recommended residual level. And then there are some issues for some of the systems with salinity and complaints about that. But this really underscores this importance of trying to find a balance between, how much chlorine can be added to these systems to ensure that the water quality is safe and there's not this contamination, but not to drive customers away from the system. And from our focus group discussions, it seemed like, more community engagement and sensitization around chlorine could help a lot with that process. And then a few other reasons why, like some people really prefer the cold temperature of sachet water. So it's often served, either from a refrigerator or on ice, whereas the piped water is warm. So especially when the temperatures are warm, people really want that refreshing, cold water to drink. A few folks thought that the water tariff was too expensive, or they didn't like the color of water, but those were really minor compared to some of these other reasons. And then the final result that I want to present is around the water system infrastructure. And we really found that there were opportunities for improvement in the risk management. So using sanitary inspections to identify different hazards, this graph shows the percentage of systems that had hazards identified for each of these infrastructure components. So for boreholes, surface water, and the standpipe tap, this was typically related to contamination sources nearby. So perhaps there's a latrine that's very close to the borehole. For storage tanks, this was typically related to the cover being partially or completely off the storage tank, so contamination could enter that way. And for the distribution system, it was typically related to exposed pipe. As a quick example, all the way on the end is an example of a picture of exposed pipe for one of the distribution systems. So, essentially there's a road here that the pipe used to run under, but it's eroded with time. And so there's a risk for, damage to the pipe as vehicles run over it that could either cause infiltration of contamination or damage to the pipe such that, there would be a complete interruption in the service. And then this is just an example, probably fairly common at standpipes, but a lot of animals are allowed to be very near the standpipe and so can defecate where people are collecting water, handling their water storage containers. And so not keeping that area clean can lead to, exposure to enter the water. And so I went over some of the issues and things that we uncovered. And like I said, this was baseline data collection. And it's baseline data collection for a randomized controlled trial that we're currently running to evaluate the impacts of water safety plans, as well as assess some of these implementation processes and challenges around water safety plans. And we hypothesize that this intervention will improve a lot of these aspects, such as the functionality, the reliability, the water quality, and consumer perceptions of these intervention systems. But, I guess stay tuned as the trial is currently ongoing, as we have, half of the systems are currently assigned to this intervention and half are assigned to control. I won't go into the details of everything we'll collect and try to measure as part of this trial, but just want to show that, we're using a very kind of detailed and established evaluation framework so that we can measure a lot of different things related to the impact water safety plans might have, from operational, financial, lots of things affecting the water service delivery. And so, yeah, I really hope that, if you're interested in this, you'll continue to follow the results as the trial is ongoing. And, if you want to check out some of the other super interesting work Real Water is doing, I encourage you to, go to the website. But other than that, I'm happy to take any questions.
Thanks very much. That was really interesting. So I think, yeah, the intervention that you're planning looks really comprehensive and sort of systemic, which has been into the discussion we've been having. But I was also wondering if you have any treatment arm that looks at just trying to change the behavior of the household, actually add additional treatment themselves, because that difference between the water that is coming from the at the point of collection versus the point of storage, that's kind of a massive part of the difference, and maybe some of that contamination, it would just be easier if the household was to change the behavior. Obviously, the household behavior is difficult to change as well,
right?
But I mean, just wondered if it was something that you considered, because also then you don't know how long the household is storing that water for. They probably have good reason to store it because maybe their supply is intermittent, so they need to have some level of storage, right? So yeah, just wondered if you considered that.
Yeah, so for this trial, we're not doing, say, a specific separate arm that's just looking at the behavior change intervention. I know there's a number of studies, I think, that have looked at things like that in the past, but we really wanted to focus on, I think, trying to deliver something that the service provider themselves might be able to do to improve that water quality. But as a part of the intervention, there will be some engagement at the community level with things like safe storage and things at the household level. So hopefully there will be improvement in those practices as well as part of this, even though it's kind of focused on the water supplier.
Yes, a couple questions. One, how are reporting measures made?
hoping it was hot, but.
Yeah, so we use the hot digital colorimeter with like the
Okay.
BPD method.
And then, did you see, actually like any kind of like disconnect between chlorine residual and E. coli? In theory, you know, if there is even the lowest chlorine residual, you shouldn't see much E. coli, but, or any, actually, I think in theory, as long as it had enough contact time, but was there, at those low levels, did you still see E. coli, you know, present in a lot of your tests?
At some of the low levels, there was still like some E. coli in some of them, but so when we were looking at, say, what we would consider a limit of detection in this area, we would probably consider 0.1 milligrams per liter. And, you know, a lot of the samples were below that, but we have some issues, with false positives for manganese, contamination. And so it's hard to decipher, you know, if, you know, it's fully a chlorine residual in that case, that's like not
We gotta
affecting everything, or, yeah.
Everyone look at it, it's not like people per billion, so. And I think
Yeah.
it isn't susceptible.
But there was a correlation, so like, you know, at good levels of chlorine, we weren't seeing E. coli, say, in that, sample.
Unless there are any other questions, we still have time, so, but. Yeah. Okay, cool, well then.
So, but I see a lot of studies where there is treatment through a pipe system and then you see increased recontamination at the household level. So what would be your policy recommendation? Like, should we continue like investing in water treatment, plants, and then, you know, having the households conducting like bad behavior or having challenges to, you know, treat the water in the right way, or yeah, because it sounds like it's not very efficient.
Yeah, I mean, I guess
on the surface. But what are your thoughts on it?
Yeah, I think I have like two thoughts on like how I would want to approach it without, say, putting all of the burden on the household themselves to like provide clean water for themselves, which is one approach, but I would like to remove that burden. And so one, I think, you know, we saw a lot of contamination and recontamination in these samples because a lot of times the chlorine levels were below the recommended level. So if the chlorine levels can be raised a bit to prevent against that recontamination with, you know, unsafe storage, I think that would help a lot. And then maybe another behavior change kind of aspect that could improve with infrastructure is like, we see household storage even with on-premise connections. And so if the functionality and reliability can be improved, like for those connections, and over time, people like realize there will be water when I turn on the tap, I think that can help improve the, you know, that recontamination and storage without, say, putting all of the burden on the households.
Yeah, really makes sense.
Environmental science. So like I was in the last like.
You know, they're like good ones.